So I think, taken together, these studies show that screen time and social media are not universally good or bad. It sort of depends on the person, I think, and the experiences that they're having, probably in real life and online. But we know that, really among all people now, screen time and social media use are universal. So what can we learn about people from all of this time that they're spending online? So I said that some of these questionnaires that we give people might take a couple of minutes to complete, but people are spending, hours and hours online. And so that's a much bigger kind of picture of what they're doing and how they're feeling potentially. And there has been interesting research looking at online activity and how this might relate to different mental health outcomes. So people have looked at Google search data and self-reported suicidality to see whether these things relate to suicide risk. And I can see that I've messed up my animations here, so I'm just gonna quickly fix this, hopefully.
I keep wondering whether Google self-harm and suicide I'm sure my browser history looks pretty gritty, and I'm like, no, really, I'm okay. I'm just teaching.
Yeah, it's a risk. I know Facebook does have they'll contact the police if you put something there, which is sort of controversial, but I'll vouch for you if they come.
Thank you.
So in this study, they were looking at Facebook data and sort of self-disclosed depressive states. So people, putting something in their post about being depressed. Similarly, in this study, they looked at the color composition of people's Instagram photos and self-reported depression. They've done something similar with Twitter, and then another kind of suicide-related study with Instagram data. So these studies are interesting, but one of the downsides is that they tend to focus on publicly available data. So they use like an API to scrape data that's available, and they infer people's mental health status based on what they're putting in the post. So if I posted something that said, I'm so depressed, it could be because I actually have depression and I'm feeling depressed. Or it could be, because my favorite sports team lost, or, something like that. So it's not necessarily that clinically useful, the way that we can see patterns in the publicly available data. So
I remember getting grumpy I was very excited reading the first wave of papers, and the tech firms are all using what's convenient. So they don't actually have diagnoses or treatment data or so tantalizing, really promising, but not actually ready for prime time yet.
Yeah, exactly. So a colleague of mine, Michael Birnbaum, started a study of collecting people's digital archives from patients at the hospital where we work to see whether we could find the same types of patterns in people who have a known mental health diagnosis. And also we've been really interested in looking at sort of their mental health history and whether their online activity changes, prior to a hospitalization or relapse. So you may or may not know this, but you can collect your archive from Google, from Twitter, from Facebook, from Instagram, and basically download all of the activity that you've ever had on that platform. So we ask the participants to do that, to sort of donate their data, and have started doing a few different studies with it. In this particular one, we were looking at Facebook posts from 51 participants who had a psychotic disorder. And we were specifically interested in seeing whether the nature of their posts changed prior to a relapse hospitalization for psychosis. And what we found was that the semantics, the words that people used in the posts just prior to their hospitalization were different. They were more likely to use pronouns. They were more likely to use words in other certain categories like death-related words or threatening-related words. We also saw changes in friending and tagging behaviors where it seemed like it was more kind of random, like doing a lot of friending or tagging all at once. And we were able to build a classifier that could, take somebody's Facebook data and predict with decent accuracy who might be about to relapse based on that information.
I had a quick question. Were you guys looking at the use of like capitalization and emojis and like exclamation marks or periods? And for the Facebook post, did that also include like sharing or like videos or other things that were already on Facebook, or just posts that they composed themselves?
It didn't include sharing, which that's actually kind of an interesting ethical question with this type of research, because obviously what you put in your own, Facebook posts can include information from other people. So people might comment on your posts, or you might, like you said, like repost or share somebody else's information. If you're posting pictures, that probably includes other people. So it's been interesting both in getting the IRB approval for these studies, but also getting them published. There's a lot of concern about the implications for other people who didn't consent. So we only looked at posts that originated from the participant. We did look at punctuation, but not emojis, unless you're using like the punctuation emoji. And capitalization. What was the other thing that you?
No, I think that was it. Capitalization and emojis and like punctuations.
One of the things that's striking to me is how we as researchers try to respect confidentiality and privacy and do the ethical thing. And a lot of tech firms are like, sweet data, and and really go pretty far before they're like, oh, was this ethical?
Right.
Anna, I was just thinking also, like, because I know a lot of people share Facebook posts that are from an actual public page, so it doesn't belong to a person. It belongs to like a public page that'll post like memes, or it'll post like videos or like inspirational stuff or whatnot. And I guess like the reason why I'm thinking about that is because there was an acquaintance that I had that that died by suicide, and because I'm a stalker, I went through his Facebook to see what he had been posting, and I was just noticing like he wasn't composing his own messages, but sharing things of like memes or like quotes or videos of things that like were pretty, you know, depressing stuff or pessimistic stuff. So it would be, I wonder if that would have a different classification behind it, since it's something that isn't from somebody's personal page they're sharing, but a public page that anybody can access even without a Facebook.
Yeah, that's an interesting question. There's another study that we've been working on with it's the same data set, but looking at pictures that people post rather than the word content. So that could pick up on some of the things that you're describing, but we didn't really look at like where the post came from. And like I said, we were focusing on ones that originated from the participant, but it's an interesting question.
I have a quick question too, if that's all right.
Sure.
Yeah, so going off of what Eric was talking about with how ecstatic tech companies are to take user data, have you had any experience with trying to get that same data from tech companies, and have they been receptive or not receptive, given that it's for like clinical studies that are maybe even from participants who are giving their consent?
At some point we had conversations with Google, and I wasn't directly involved in those, but I know it didn't go anywhere. I don't think that we've tried with Facebook, but the study that I just mentioned where we're looking at pictures from Facebook, we're collaborating with people from IBM, and IBM doesn't have a social media, but they're interested in being able to learn about picture classification, and they're sort of interested in developing the methods and using the data that we have. So that's tech of kind of a different sort. I do know that tech companies, Facebook in particular, is very interested in hiring people who have this type of background, who can analyze data but interpret it, you know, so they have the clinical expertise to understand what the patterns that they can find might mean.
Are the natural language processing and machine learning, is that R or Python or TensorFlow?
We don't use natural language processing because the like the grammar of online posts often isn't
LOL
correct. Yeah. So there's something called Luke, which is an acronym that can't think of what it stands for at the moment. But it's basically a dictionary that categorizes different words into categories of type of word, and then we can see if you're posting, like when I mentioned pronouns or death related words or biology related words. So it's just looking at the words more than like the structure of what you're writing or how you speak, how you're writing.
Would it be able to detect sarcasm or a deadpan irony?
Definitely not. Yeah, it just like takes the words and sort of counts them. Like this word is a pronoun, so we're going to count up all the pronouns. So it's not that sophisticated. Whereas natural language processing is able to do that type of thing, but I don't think it works necessarily on social media posts. But it can, you know, people have done studies with natural language processing to detect, you know, early dementia or, you know, like different cognitive problems based on people having word finding problems or speaking in a certain way that is indicative of cognitive change. So I think that is technically like a more powerful approach. It just doesn't, at least now, it doesn't kind of apply to social media because they tend to train the natural language processor on other types of language.
Right.
This reminds me of when I was your age, Jamie Pennebaker was having people write in diaries and then having an army of research assistants transcribe and code the stuff in the diaries using the LIWC program.
Oh, that's the Luke.
Oh, that's, so the cool kids actually say that. Not,
yeah.
huh.
Yeah.
Huh. Okay. And then Natalie Hong in the chat was talking about some of the things that people are finding are face valid. So black and white filters or more dark and blue pictures, or the people are smaller in the pictures, were some of the initial findings. And the other stuff like pronouns, if that replicated, that would be really cool. But where, I mean, you're obviously much more up on this than I am, but I am curious, but not enthusiastic yet, because I'm not sure that we could actually hang our hat on a lot of that.
I agree.
Luke.
The pronouns thing we did replicate in Google search, but it's a lot of the same participants, so.
By pronouns, do you mean them just like using pronouns when writing, or specifically about people who may be trans or dealing with like LGBTQ issues? Like what do you mean
like
by that?
Like if I had a post and I said I, me, we a lot, it's just, yeah, the actual use of a pronoun word. So this study was kind of a similar idea in being interested in being able to look at different diagnostic categories and relapse. So for this study, we had more than just people with psychotic disorders. We had healthy volunteers, some of whom actually came from UNC, people with psychotic disorders and people with mood disorders. And we were looking at Google search. This particular graphic is looking at the volume of searches, so how much people are searching on Google prior to their initial hospitalization. And so people who are healthy volunteers don't have a hospitalization. We just looked at their study enrollment date, but you can see overall the healthy volunteers search Google more than the patients do. And then because I'm interested in sleep and activity, I think this is kind of a cool finding. The healthy volunteers are searching less than the two patient groups overnight. So 0 is midnight. So from midnight to 6 a.m., the patients are searching more, which would suggest that they're more likely to be awake and active overnight. Whereas the healthy control group is searching more kind of during typical like daytime business hours. And I didn't include this in this particular presentation, but in the same paper, we also have information about the terms that people were searching. And that's where we found also the pronouns were more prominent the closer you got to hospitalizations. And then in another study that I've been working on with one of the residents, we were looking to do more of a qualitative study of people's search to see whether people who have a mood disorder and had been hospitalized due to either suicidal thoughts or behaviors were searching for suicide related themes prior to their hospitalization. So we found that more than 60% of the participants had a suicide related search. So just to give some examples of that, different methods that people might consider. And 20% of them had searches that directly related to a method that they had used in a suicide attempt. We also found that about half of people were searching about mood or anxiety symptoms. So just some examples of what those searches look like. And then we also found that people had health related searches. So about 80% of people were searching for, some of them were looking for specific clinicians or for therapists or, some of the things like you see here. So I think something that's sort of interesting and potentially useful from this type of study is that, we see that prior to somebody doing something to hurt themselves, that they are looking online in many cases for information related to suicide, but also help seeking information. And this is something I'm going to return to later in my talk, but I think, this could be an opportunity for intervention. So another way that we can get some data about individuals, as I mentioned earlier, is from their smartphone. And there's this idea of a digital phenotype. So basically, what do you look like digitally? Which has been defined as the moment by moment quantification of individual level human phenotype in situ, meaning like in your daily life using data from personal digital devices. And I think that this type of digital data can help us to overcome some of the challenges that I mentioned earlier that we have in making clinical assessments and diagnoses. So I mentioned that, people may have an episodic disorder that looks different at different times. And if we're collecting data from their phone, it sort of goes across episodes. So we can see what they look like both in and out of mood episodes. We see that the data are collected all of the time, which might help us get some more finer grained information about non-specific symptoms. So is somebody's irritability happening all of the time, or are they more active all of the time, or is it just some of the time that they're like that? It's also independent of self-report. It's just collecting this information as you go about your normal routine. So we don't rely on people to tell us what things were like in the past. And it's also less subject to bias. So there's, some interpretation of this data that has to be made, but it's more quantitative and less qualitative in most cases. There have been a few other studies looking at data about people's smartphone use, and I should describe the type of data that we're looking at. So this isn't really about people like doing social media on their phone or something like that. It's really about how they're interacting with their phone. So for example, how many messages or calls they make, where they are and how mobile they are, and then, potentially voice features that you could get from people's phone calls.
Does that also include like how many times they're tweeting a day? or?
Nope.
Okay.
It's more like metadata sort of about how you're using
Right.
your phone in most cases, rather than what specifically you're doing. So there are a
Okay.
number of different apps that have been developed to collect this type of information. And they get information mostly from your phone's sensors. So for example, smartphones have a gyroscope in them that tells us how the phone kind of moves around in three-dimensional space. It has an actigraph in it that tells us how quickly it's accelerating in forward motion. You know, we all are probably fans of Google Maps. So there's a GPS system in the phone that, you know, can track where we go, how far we go from our home. It can also, this only works in Android phones, not iPhones, but it can see how many calls there are, whether the call was initiated by the participant or just received by them, and similarly with texts. And then there's also data showing that how well and how quickly you type on your phone keyboard is related to depression symptoms. So one thing that I like about this is that even though you know, how you use your phone is personal, this isn't really collecting any content. It's more, like I said, sort of the metadata about how you're using your phone. So you don't have as many of the issues, ethically speaking, in terms of like what someone's posting on Facebook and whether other people are, you know, involved in that and so forth. So I'm currently conducting a study called the digital phenotype of bipolar disorder. And we're recruiting adolescents who have bipolar disorder, and then a comparison group of typically developing adolescents. We're recruiting them from the inpatient and outpatient clinics where I work, and then the typically developing participants through pediatricians, schools, through Northwell, like employees, kids, and so forth. And what we do is, once we've consented the participant and their parent, we do a neuropsych exam to get some information about their memory, attention, and some other executive functions. We do a full diagnostic interview, so we get a good picture of whether or not they have bipolar disorder, but also if they have any comorbid disorders. And then both the parent and the participant fill out a number of self-reports all about the participant. And then we install the app that we're using, which is called BWE. And BWE collects this passive sensor data, and it also gives people surveys a couple of times a week where it just asks them about their mood, it asks them about their sleep, whether they've been taking their medication. Each one takes about a minute. And then we're following them for 18 months. And during that time, BWE is running all of the time. And once a month, I do a follow-up call with the participant and with their parent, just to get more specific information about how they've been doing in the preceding month. And then at the end, we're hoping to collect the digital archives from the participants. So we have a really detailed view of what's been happening with their mental health, with their behavior over this 18-month period. And we can sort of match these different sources of data to their symptoms over that 18-month time. And what my hope is that we can define what this digital phenotype of bipolar disorder looks like over the course of the study. And then in a future sample of adolescents who have bipolar disorder, we could collect the data without those follow-up calls, and just looking at their app data, we could see oh, this person's mood is changing. You know, they might be heading for a mood episode, for a relapse, and kind of identify an opportunity for an intervention and hopefully prevent them from getting worse and from needing to be hospitalized, taken out of school, and all of the consequences that come with that. So being able to predict relapse is one of the main study aims. Another one is to be able to identify this phenotype of bipolar disorder in people who might be at risk. And that's where the typically developing adolescents come in, where we'll see, does the way that adolescents who have bipolar disorder interact with their phone differ from the way that typically developing adolescents do? And is that a pattern that we can identify in a new sample of people? So we can see, you know, what does your digital phenotype look like? Is it more similar to the typically developing kids, or is it more similar to the adolescents with bipolar disorder? And if it's the latter, it might be a good opportunity to do a psychosocial type intervention that we've seen work in other high-risk populations. But this could be easier because it just requires an app, and potentially screen a lot more people than we can do in other types of high-risk samples that usually require a parent with bipolar disorder or somebody with clinically significant symptoms already.
Ron Define wrote in and asked if you're looking for subjects from other places besides Northwell with the diagnoses, or especially with everything going to online.
Well, that's what I was going to say. If you asked me in February, I would have said no. But now we're doing all of our baselines virtually, and then the rest of the study is really all virtual anyways. So yeah, we could potentially enroll people from outside the health system. Yeah, that would be cool. If you're interested, contact me. It's actually been interesting to me because when the social distancing and stay-at-home orders started, I wasn't sure what would happen. I think that's true for most people. But we were, you know, trying to get some participants that we that we'd had scheduled to do like a video baseline, and people were very reluctant to do that. But now that it's been several months, it's the actual recruitment part, I wouldn't say is easier, but scheduling people is easier, and we have fewer no-shows because in general, I think it's just less complicated if you don't have to go somewhere and like after work and all of that stuff. So. So if part of the goal of this type of research is to identify more people who would benefit from mental health services, then we need to expand our capacity to help people, in particular for psychotherapy. So the treatment guidelines for most mental health disorders, for young people especially, recommend psychotherapy, either alone or in conjunction with medication. But it's really difficult to find therapists for young people, even here in New York City, where there are a lot of people who are psychologists or social workers or other type of mental health providers. I have a really hard time when I have a participant or somebody else who needs a referral for treatment, because there are often waiting lists, particularly for any providers who take insurance. So if you have a lot of money to spend, it can be relatively easy to find somebody, but otherwise it's extremely challenging. And I find it really frustrating that we don't have more to offer people. So there's sort of a responsibility, I think, that if you are going to diagnose people, that you have something to offer them. The US Task Force for Preventative Services, I think that's what it's called, publishes sort of guidelines about screening, and they recommend screening for depression in adolescents, but only if the setting within which the screening is taking place can actually offer referrals. And they don't recommend screening in kids, like elementary school age kids, in part because there aren't necessarily providers who are trained to treat them. And it's not necessarily helpful to a family to say, your child is depressed, but sorry, we can't help you.
Good luck with that.
Mm-hmm. So one possible way to help more people is through technology. And I think there's a lot of excitement about apps, but people are also intimidated because there are literally more than 10,000 mental health related apps, and probably even more than that now. And so how would you ever pick one? And if you're a consumer, how do you know which one to pick? And if you're a clinician and you feel maybe more responsibility about making a recommendation, how would you know which one might be good for somebody? So luckily, apps can be effective, and particularly for adolescents, digital interventions, which includes apps, but also like teletherapy and online kind of psychosocial interventions, are often preferred. And in a meta-analysis, they looked at 34 RCTs of different digital-based interventions, and overall found a relatively small effect size, but not one that's much smaller than what we see in kind of traditional psychotherapy trials. And if you have an intervention that's evidence-based, the effect size is bigger. And if you have a digital intervention that includes a person, so somebody who's kind of guiding you through, somebody who's holding you accountable, then the effect size is larger still, and can be on par with in-person interventions, but require fewer resources. I think one of the biggest challenges of using apps or digital interventions effectively is that taking something from academia and getting it to the market takes on average 17 years. And 17 years ago, this is what cell phones looked like, and they didn't have apps. So if we rely on the pipeline from academia to the market, then we're really never going to have something that's really able to serve a lot of people. I looked in the App Store for apps that were included in the meta-analysis that I just referred to, and I could only find 2 of them. So if it's something that you can only get when you're in a research study, then you might as well be giving people, human to human psychotherapy. So even though we're publishing on this, you can see over time the number of PubMed citations are growing. This isn't something that's helping people yet. There are, like I said, thousands of apps in the marketplace that are developed by tech companies. But we don't really know a lot about whether or not these can help. So only about 1/3 of them cite any information at all about any market research or, research. I shouldn't say market research. I'm sure they do that. What they don't do is research about the efficacy of the app for the symptom that they're trying to change. And a lot of them don't include any evidence-based content. A few years ago, I had the students in my lab start to compile a list of apps that we could refer people to that would be helpful. And we came across stuff like, there was one that was marketed to people who have bipolar disorder, and it was recommending drinking alcohol when you're manic to help calm you down. I mean, it's like, can be really harmful information in some cases. Another issue with apps is that people don't really use them. So similar to the Fitbit, we see that in the real world, people tend to stop using apps after less than 5 days. And I know that if I look at my phone right now, I have dozens of apps, many of which I've only opened once or maybe not even that many times. So obviously, if it's just sitting on your phone, it's not doing a lot of good. I think another one of the challenges is that the apps that are developed in academia might not be that appealing to young people in particular. And I wrote a commentary about this with a colleague of mine, I guess a couple of years ago at this point. But if you think about what you're competing with, if you want an adolescent to be using an app that you designed. So this is a screenshot from an app that was developed by Mayo Clinic to help with anxiety. It's evidence-based, they've done research on it, but it's very plain looking. So you can look at that, or you can look at Snapchat and your friends and your favorite celebrities. You can do your activity to rate your anxiety, or you can be, on Instagram. So I think we need to be thoughtful about sort of the aesthetics and the design of these apps. And they've done research on this and describe something called persuasive systems design. And by using this approach, or I should say that interventions that follow this approach tend to be much more effective, primarily because people actually use them. And the main sort of criteria that they've identified are surface credibility. So does this look like something real that can actually help me? Dialogue support. Am I going to interact with another person, or is this just me on the app by myself? Is the interface appealing? And is it something that I can do quickly? So a typical psychotherapy session might be 45 minutes or an hour, but I think very few people would spend that much time on an app, like reading content or something. So it's a mistake to try to take what we do in real life and just move it to an app. We have to really think differently and think about, people like really short videos, people like pictures, people like doing like quizzes or things like that. So how can we take our evidence-based content and turn it into something that's more digestible like that? And then self-monitoring. So people kind of like to see over time if they're improving or things are changing. I'll just go quickly through other things that you might consider when selecting a mental health app, either for yourself or if you were a clinician for working, for recommending to a client. So what is the problem that this thing is supposed to address? And does it seem like it could actually do that based on what the app has the individual do? And is what they're doing evidence-based? Can you see that it's coming from a good theoretical background? What's the cost? So there are a lot of apps where it's free to download, but then there are a lot of costs that can come up as you use it, which can be awkward if you're a therapist and you recommend this to somebody and then they're like getting all these charges. Another thing to think about that might not immediately come to mind is how long has this been in the marketplace? One thing I definitely didn't appreciate before I got interested in this area is phone updates, which happen pretty often. And if you're an app designer, it basically breaks the app over and over and over again. And so if this came from, you know, like an academic person who developed it for their one study, they're not going to be maintaining that as they go forward for every, you know, iOS update that happens. And then the other thing is data security. So I think Facebook in particular has taught us that if something's free, you're probably the product. And if you're using this for a mental health reason, I think that can be particularly sensitive if all of the data is being fed back to the company. There are a few sites that rate mental health apps specifically based on criteria that are similar to the ones that I just went through. One is mindtools.io. So they do kind of an evaluation of different things. The other one is CyberGuide. It's kind of a similar idea. So I definitely recommend looking at those two sites if you're thinking about one of these apps. And then I think in the interest of time, I'm going to go through this very quickly, but these are just different kind of domains where I think there are good options for apps that you might want to incorporate into clinical practice. Mindfulness is great, and there are really good apps that can guide people through learning mindfulness. I also find that doing different trackers, so in therapy, we're often asking people to track their behaviors, to track their mood, to track their thoughts. And, you know, if you give a teenager a worksheet and say, you know, take this with you, and every time you have a negative thought, I want you to write it down, they won't do it usually. But if you say, hey, can you like put this Google Sheet in your phone and just track your mood? Or can you do a thought log on your phone? You kind of meet them where they are, and they're much more likely to complete it. Medication compliance can be tracked with an app. And then there are a few safety planning apps for people who might be at risk for suicide. And again, I think this is really handy because it's always there. If people start feeling distressed or suicidal, they can immediately go to their safety plan. There are also a number of telepsychology or teletherapy apps that have become popular, like really pervasively advertised, at least recently. So Joyable, BetterHelp, Talkspace, and these all kind of follow the same format, which is usually sort of asynchronous chat with a therapist, or like brief coaching calls along with some CBT content, which can be a good kind of gateway therapy, I think. One of the things that I think apps can help with is sort of empowering people. So giving them more information about themselves so that they can be motivated to make changes that will benefit them. And I've been inspired by work by James Hudziak at University of Vermont. And he created this program there called the Wellness Environment. And the goal is to promote healthy behaviors in college students through technology. And so students who sign up to be in the wellness environment live in special dorms, and they get rewarded for tracking their behavior and also for engaging in healthy behaviors. So they have an app that they use. The app has them do a survey every day where they report on different types of behaviors like exercise, meditation, drinking, drug use, nutrition. And they get paid not in money, but in Wii coins is what they call them. And so you can earn these Wii coins when you engage in healthy behaviors, and then you can trade them in for different things. You can also, this is like a meditation practice, and then it will sort of check in with you about different goals that you might have. And I think this is a model that can also work for psychiatry patients. And in the hospital where I work, we're trying to develop something where we can empower patients by giving them more information about themselves, but also use that information clinically that we collect through apps. So we can collect more information about people's sleep, for example, how much time they're spending at home, how many steps they're getting, along with mood ratings, and start to make connections. So you can see, oh, when I sleep more and I'm more social, my mood is also improved. People who participate in this program would also have sort of a digital care coordinator to help facilitate their participation with the app and with other sort of technology enhanced services, and also the opportunity to participate in research that we're doing that is novel and technology based. So like the online archive research that I described, or different types of novel interventions for, there's one for smoking cessation that a colleague is doing, or virtual reality therapy, different things like that. Okay, so the last thing I'll say is just how we can kind of get people who might be experiencing symptoms to actually seek help through some technology means. So where do young people go if they have health questions? The main place is Google, which shouldn't be surprising to anybody. And we did a study a couple of years ago where we interviewed people who had come for their first visit to the hospital where I work for psychiatric services, and just asked them, how did they get there? You know, like what were the steps that happened before they eventually decided to seek treatment? And a majority of the participants said that they had sought help or information online beforehand. Many of them said that they wouldn't be comfortable putting anything about their symptoms or their personal experiences on social media because they were worried about judgment from other people. But they said that they would be willing to talk to a clinician online, which is interesting. So that could be a way for somebody to engage a person who might be searching certain things. If they had an opportunity to talk with a professional, they might do that. But the gap from when people had their first symptoms to when they came for in-person help seeking was about 2 years. So people were spending, you know, potentially a lot of time on Google in those years when they could have been getting help. So my colleague, Michael Birnbaum, I mentioned before, did a study with Google AdWords where they were particularly interested in getting people who were experiencing first episode psychosis into treatment. And so they bought ads based on people's search terms that might be related to psychosis. And a lot of people clicked on the ads actually, but ultimately only 1% actually clicked through to their website and ultimately contacted a treatment provider. So he's doing a new study now where they're trying to engage people better, to get them to actually come to treatment. So they're using more of like a chat type thing. So you may have seen, if you go to a website to buy something, sometimes a chat will pop up and say like, oh, can I answer any questions? Do you need help? So it'd be something more like that to try to encourage people to have a conversation about it. I also think that peer support can be a valuable tool online. So even though people may not want to disclose symptoms that they're experiencing to their own social network, we know that people do benefit from talking to other people about what they're going through. And I think there are some good examples of how peer support in particular can be helpful. So for example, some of you may be familiar with the It Gets Better project. And when I first heard about this, it's, people record videos for LGBTQ youth talking about how their own experiences of coming out and how things do get better over time. And I just thought that something like that for young people who are experiencing mental health problems would be really powerful, because in my clinical experience, a lot of them feel very alone and isolated, and like other people aren't going through something similar because they're always afraid to talk about it. There's also Trevor Space, which is more of like an online social community for LGBTQ youth. There's Crisis Text Line, which I think is so smart because it took something we know is helpful, like a suicide hotline, but made it text-based, so it's more accessible to young people now. There's also Talk Life, which is kind of an anonymous chat about mental health. So I'm doing a study now called Love's Company, which is basically an online social community for adolescents who are sort of self-identified as having psychological distress of any type. And people are randomized either to this Love's Company online community or to just an informational website. So it looks like this. People can post different topics, comment back and forth. The informational website looks like this, and it just has psychosocial psychoeducational information about different mental health conditions, about apps, different things that we think would be useful. And so far, we've had pretty positive feedback from the interactive site, that our participants feel like it's positive for them to be able to talk about things that they're going through, but also just to read what other people are posting and recognize their own experiences in other people and see that they're really not alone in what they're going through. Clinicians also go online for help. And if you are at an academic institution and you have a library that subscribes to different journals, you can get access through PubMed or PsycInfo or other online search tools. If you're a community clinician who works in a private practice or a group practice, you probably don't have that library affiliation. And so you might go to Google to try to figure out what are the best tools or what are the best interventions. And as I'm sure many of the people listening are aware, Google is likely to direct you to Wikipedia based on a special relationship that they have. And so if you want a community clinician who's searching for the best mania screening tool to actually find it, a good place to put it would be on Wikipedia. And so HGAPS has done a phenomenal job of updating Wikipedia pages, creating new pages to help make this information really accessible. In the past few months, we worked to create a page about telepsychology, both for clinicians about how to provide services, what's the evidence for services provided virtually, and also for patients so they know what to expect, how to prepare, and so forth.